Good morning, everyone. Welcome to the NATCAN session in London Global Cancer Week. We've titled it Driving Improvements in Cancer. This session is all about quality. It's one of the key important ingredients for health service and system strengthening and delivering the care that we wish to our patients across a variety of diseases, across a number of different modalities. And it's not just in the diagnostic pathway, treatment pathway, but also in the survivorship and experience elements of that as well. We've got, next slide, please. We've got a sort of diverse set of talks, which start with me, where I'm actually going to focus a bit more about why performance in cancer care is important. The word performance can be controversial, but you will see as I dissect this, why it matters no matter what country you are in the world, no matter what center you're in, whether you're in the public sector, private sector, quality is extremely important. I'm then going to also frame up where NATCAN, or the National Cancer Audit Collaborating Centre, which is a UK initiative, comes into this as a quality management programme. And that will be followed by Dr. Sugita Sukumar, who will talk more around NATCAN's work, but importantly, how this can be applied to different settings, not just high income, but low middle income as well. We'll then move further forward, because all audit programs are nothing without the quality of the methodological input. I'm delighted that we'll have Professor Kate Walker, our senior methodologist, who will talk around how we use that data, how we can look at disparities, and how we can influence clinical practice change. And finally, I'm delighted that Dr. Julie Nossiter, who is the Director of Operations at NATCAN, will be discussing something extremely important: how we involve the patient voice in everything we do about quality, because ultimately that is our aim, is to improve patient care and experience and allow people to live longer and better. So I'm going to kick us off with the first set of slides. Next slide, please. As I said, around driving performance in cancer care. So let's just ask the question, because there's still maybe many people who are not converted to the idea of the importance of quality. But for me, it starts with transparency around the effectiveness of care. It's not just a case of, here I have this lovely surgical equipment or this radiotherapy machine that I've purchased, and I'm going to deliver effective care. That just does not happen. It might sound an obvious statement, but it's amazing how a lot of safety or a lot of our perspective is built in on what we provide rather than the quality of how we deliver it. I think transparency is important from a safety perspective, and I'll give you a UK example of that, but also ensuring the patient-centeredness of care. Without actually reporting outcomes, without understanding what the hospital across the road, or a hospital 50 miles away or 200 miles away, you don't know around best practice. You might all be offering evidence-based care, but are you offering it equitably and with the relevant quality? And if there is a gap, that's what supports quality improvement and where audit's important. Now, there are a number of healthcare systems where it's incredibly important for patients to be able to choose where they have their treatment. They have that choice. They need information for that. And it's amazing the number of mature high-income systems and low-middle-income systems which rely on patients deciding where to have their treatment and paying for their treatment, which has very, very little information on the things that matter, particularly around the quality of care. I'm also going to explain how that information asymmetry, or that lack of knowledge about the quality of care, can also result in a lot of low-value practices, and I'll come into that concept of value integrating or emerging within our care system, which waste resources without necessarily providing meaningful benefit for patients. Next slide, please. So let's talk about the safety experience. And this is something that did happen in the NHS towards the late 2000s, where there was a reporting of standardized mortality rates, and they found that this hospital, Stafford Hospital, had higher rates than any other hospital, significantly so. Now, when you're looking at mortality rates, by and large, all the hospitals are extremely close together when you report them. But this hospital had significantly high rates, and it was particularly noticed for those individuals coming through acute or emergency care, and particularly for elderly patients. This caused a scandal, and I say a scandal. The hospital closed. The hospital does not exist. So we can see how the transparency in the reporting highlighted a safety issue for care and resulted in a reconfiguration of the service, but also changed our perspective on the importance of measuring outcomes to ensure that we're avoiding a similar situation in the future where we expect with 150, 200 hospitals that the care would be similar, but actually that's not always the care. So we need a safety netting in place as well, which audits allowed for. Next slide, please. The other thing to mention, and this is work that I did a few years ago now, it's a map of England, as you can see, and the NHS, although it's a publicly funded system, supported the role for patients to be able to choose where they have their treatment, and that would be publicly funded. And I looked specifically at prostate cancer, and particularly around patients needing surgery. And if you look at this map of England, you see these green dots around a cross. So that cross is in Cambridge, and the green dots are all the patients who live close to Cambridge who had their prostate cancer surgery in Cambridge. But you then have these blue dots, which represent patients who had another treatment centre. So the treatment centres are the ones with these crosses closer to them, who decided to travel to Cambridge for their treatment. People were coming from London, people were coming from the East Midlands, parts of East Anglia. We hadn't seen anything like this before. Next slide, please, just for the animations. What we found that 1 in 3 men were moving to a centre other than their nearest for their surgery. They tended to be younger, fitter, and more affluent. But what was driving this? So two of the biggest drivers was the reputation of the hospitals, often the media reputation. But the other factor was that they were going to 10 or 12 hospitals that were the early adopters of robotics. So there were 65 hospitals, and 10 or 12 of them had robotic surgery. We did this analysis, and we saw that patients within the NHS were going to these hospitals with the perception that they were getting better treatment. What then resulted is that all the hospitals now, sort of 95%, have robotic surgery because hospitals were losing patients to these other centres. So we're now in a position in the NHS where we have about 50 radical prostatectomy centres, and they all have robotic surgery. However, what is the missing ingredient? Do we know whether patients have better quality care as a result across the board in the NHS and these individual hospitals? Next slide, please. You'll get used to seeing this. This is a funnel plot. So what we see here is on the x-axis, the number of surgeries done at each of these individual hospitals, which are represented in the dots. The y-axis is the percentage of severe urinary toxicity after prostate cancer surgery, something we obviously want to avoid, something that patients want to avoid, but something importantly that represents the quality of care. This information wasn't present when that analysis that I showed was before and when robotics got adopted. But what we can see is that there's a significant variation across hospitals of providing prostate cancer surgery in the rates of severe toxicity, so from 2% to 28%. But the message that I'm saying is that they all have robotic surgery. So we've not driven the performance of robotic surgery in terms of quality because there are other elements of the pathway that drive that over and above the technology that you deliver. And you could argue from a value perspective that the investment in robotic surgery hasn't had a return in terms of quality going forward. So this for me is another important reason why benchmarking and measuring outcomes is extremely important at a population level across hospitals. Next slide, please. So one of the questions that comes up is what indicators to measure. We'd love to measure outcomes or be able to very well, toxicity, recurrence, patient-reported outcomes, but they are the hardest to collect. So most programs or quality programs that you see internationally will look at structure, how many machines do we have, how much staff do we have, but as well as processes of care. Are people getting evidence-based treatment? Are they having the relevant staging that they require, or as guided through the evidence portfolio? What is key, irrespective of what indicator you have, is that it must be actionable. This is not a research question. Indicators aren't used for research. They're used to drive quality. So if you see a variation in that quality, you need to be able to act on it. And often outcomes are much harder to do so. What's also key is that the vast majority of indicators have been developed in the high income setting. Very, very few have been developed in the context of the low middle income country setting. And very little attention is paid to actually how you report that data or quality improvement. It's almost the missing link, which I'll come to. Next slide, please. So just from the global perspective, one of the pieces of work that I did a few years ago now in collaboration with the City Cancer Challenge, ASCO, WHO, Aortic, and the National Cancer Grid of India was around, well, can we define a minimum outcome set for cancer care? any hospital in the world providing cancer care, what would be the sort of 8 or 9 or 10 indicators that they should all collect? So this was a collaborative piece of work, international piece of work, and it had a number of phases. Next slide, please. The first phase was to look at the literature. I can't tell you, even a week ago or 2 weeks ago, I got an email saying, we're thinking of developing quality indicators for radiotherapy. We're thinking of developing indicators for medical oncology. Please look at the literature. There's hundreds already. And we were looking for indicators that had already both been published and are being used in quality improvement programs. So we identified 216 quality indicators, 65 in radiation oncology, 88 in surgical oncology, and 63 in medical oncology. So there's plenty in the literature. So do please look at that before you decide on your own expert panels to develop new indicators. We then had a series of workshops, and we decided with our low-middle-income country and high-income collaborators that we'd go for 34 indicators or a short list of those. And then we went through 2 international Delphi consensus rounds, which were supported by Aortic and ASCO and WHO and the City Cancer Challenge. We had 145 participants in the first round and 30 participants for the second, and 9 core indicators were selected. Next slide, please. I just want to give you a selection of them. So we tiered them. So tier 1 is, this would be expected in any country in the world to be able to be collected. It included, has a biopsy been done before initiation of treatment? Have we got complete staging? What's the average time from a patient's diagnosis to treatment? And what are the proportion completing treatment? I don't think there's anyone online who doesn't think that these are a sensible set of indicators. And even starting to collect these pushes further forward in terms of looking at the variation in quality of care. Next, please. Tier 2 indicators were very much more focused on that more in-depth level. Are we doing the right surgery? A mastectomy versus a lumpectomy, for instance, or are all patients receiving multimodal treatment? So the brachytherapy after external beam radiotherapy for cervix cancer. And there was a general expectation that you don't necessarily need to do it for all cancers to begin with, but breast, cervix, colorectal and prostate were considered the most relevant in that in the lower resource setting. Next slide, please. But as I've written here, you have the indicators, what next? And so we need to understand how we create a quality management program, and that's very specific to a country. Some countries have just done, oh, well, we have a registry for surgical care or radiotherapy care, or you can have the cancer audit style that we are looking at breast cancer care across the whole pathway. You need to decide, is the coverage local, hospitals, regional, international? Where's the data going to come from? Are we going to expect people in the hospitals to complete that data? It's extremely time consuming, and no one's going to be able to collect 50 indicators, but they might well collect 10 indicators, for instance. How is that going to be fed back? At the hospital first? Is it going to be done regionally? Where is the governance in that? Is it going to be done transparently, and who's going to act on it? And then most fundamentally, how and who is going to be responsible for the quality improvement. And that's where we're going to go to, particularly in these presentations, as to how you can make that a reality, giving examples from the UK, but also how that can be translated across. Next slide, please. And our particular focus will be on NATCAN, the National Cancer Audit Collaborating Centre, which commenced in 2022. Next slide, please. And this is the largest cancer audit program in the world. Our QR code is our paper on this, and we compare it to other quality management programs internationally. But we focus on 9 cancers. There's 2, I'll put 10 there because for breast cancer, there's 2 audits, one for primary breast cancer and another for metastatic breast cancer. And the reason for that is the complexity of the care pathways for metastatic breast cancer now. But we assess the whole path of care: diagnosis, treatment, survivorship, experience. It's mandated by the National Health Service, who fund this, and it covers all public sector hospitals in England and Wales. So just to give you an example, for colorectal cancer surgery, there are 160 centres, public sector hospitals in the country, and all of those are covered. Likewise, there are 30 lung cancer surgical resection units, but we will cover all the hospitals providing diagnostic services for lung cancer. And there's a clear system of reporting and feedback. Next slide, please. And just again, I think there's another animation. So what are the principles just to think about? There's political commitment. I talked about the Stafford Hospital and how that closed. So there's political commitment from the NHS about transparency of care and the use of data to drive improvement. That is very important. There's funding for this initiative, and we work in partnership. Professional bodies are extremely important. If a professional body said, well, actually, this is not worthwhile, we don't require this stops dead very quickly. But also importantly, we involve civil society and patients to make sure that we're asking the right questions. Clinical and methodological collaborations at its core. What do I mean by that? I would love to have a long list of different types of indicators, but the reality of delivering it, the reliability of those indicators, and the fact that you can do fair comparisons live and die by the quality of the methods behind the development, and particularly from an epidemiology perspective. You need outcomes that are measurable, and as I mentioned, we report publicly, and where possible, we use pre-existing data sources. So we use the cancer registry data and we link it with other available data sets, which reflect on national data sets, which reflect on activities for radiotherapy, surgery, and systemic therapy, as well as outpatient care. Next slide, please. So just to give you an example, I mean, this is a slightly old photo now, and this was the National Prostate Cancer Audit Team before I became director of NATCAN. Was involved with the National Prostate Cancer Audit back in sort of 2012, 2013. And one of the things that we wanted to do is that it was traditionally, most of the audits were surgical audits and surgical care. I think it would be fair to say our surgical colleagues have been ahead of the curve in terms of quality improvement and auditing. And so we really wanted to look at indicators that matter. And these are two papers which took 2 or 3 years to develop indicators that matter after surgery. So severe urinary complications, you saw that on my first graph, which showed the variation across the country. And another, which was, from my perspective, looking at outcomes from radiotherapy. So this was reporting genitourinary and gastrointestinal complications. It took a lot of time, and you can see here just the number of people involved, both in terms of the statistics, epidemiology, and the clinical input, as well as people to actually run these analyses and validate it. So it does take time, but it does pay off further down the line. Next slide, please. In terms of what we measure, we look at some data completeness, waiting times, the diagnostic pathways. Are we using the right diagnostic elements? Treatment variation. Are people receiving evidence-based care, but also outcomes, and that can be toxicity and survival, as well as staffing. Next animation, please. And again, what we can see here is an example from the National Ovarian, just again, please, from the National Ovarian Cancer Audit, which we reported 1-year survival, and we can see across these sort of centralized systems for ovarian cancer care, and there are 40 of them in the country, there's a big variation in 1-year survival. Next slide, please. And the point I'm trying to make is if you measure it, you'll always find something. The number of times I've presented and individuals have said to me that they're absolutely sure that they provide good quality care. And you ask the simple question, show us, how do you know? Now, people might have their own little database, their own Excel spreadsheet, but unless there's a common nomenclature for what you should measure and how you should measure it, and a fair system of comparison and reporting, you won't see any differences. So what we find is that across the audits, 50% of patients are not receiving evidence-based care, so there's an implementation issue. That's a general aggregate figure, but across the trusts, that can vary between 20 and 80%, so huge variation. And this is looking at drug treatment for kidney cancer. When people have the treatment, it's not necessarily given with the right quality, so complication rates, readmissions, and mortality. We would know none of this if we don't measure it, and there are often substantial delays. Next slide, please. And again, please. We have many different ways of reporting. I've talked about our feedback and our dashboards and our annual reports. This will go into more detail in the further talks. There'll be important things around setting targets. Are there particular populations that don't receive treatment, such as elderly populations, or geographically, if there's a difference? If we feedback, how do we make sure that that actually achieves change? But I just want to go into something which is our outlier program. It's my last slide, pretty much. If you go to the next slide. And what I mean by that, so this was the first reporting program for radiation oncology. Funnel plot again, I'll explain. So each dot is a radiotherapy center. There are 50 on there. The x-axis is the number of patients treated at each of those centers. And one of the indicators that we developed as a team was around gastrointestinal toxicity after treatment from radiotherapy. And what we found is that on average, grade 2 or above toxicity after prostate cancer radiotherapy was 10%. But we can see this variation, and in particular, we see outlying variation. So the ones circled at the top, they have complications 3 times higher than the national average. As the outlier program, we contact them in advance of reporting the results, and they're asked to check their results and give a right to reply. They did confirm those results. At first, it was this data's not correct. You've got the wrong time period. This is something that we don't recognize. Most people don't recognize their care. But what was interesting is that they identified some of the issues or the fact of iteration of the care. So they all had IMRT, they're all using protocols, but care had moved on. And so they used evidence from the protocol of the best performer, which you can see lower down with 2% toxicity rates, changed their protocol. And I'm pleased to say that the toxicity rates for the one with the high toxicity is now at an average or below average level. So this does work at a population level. Next slide, please. So ongoing challenges, we're trying to appraise pathways of care rather than modality specific. I'm particularly often concerned with how do we use this data to drive local quality improvement? How do we get people to look at the data, act on the data, and give them the tools to do so? Fundamentally for me, particularly in radiation and medical oncology, I'm a clinical oncologist. We need performance champions and people who understand the science of performance. So there is a lot of training that needs to be done around this. And also, as we move forward, united in our approach to common themes that are occurring across the different cancers that allow hospitals to tackle this at scale. So I thank you for your attention for this presentation. I'm going to move on. For questions, please put them in the Q&A as we go through. We will have time for questions towards the end, but for the sake of time, I'm going to move forward. The next presentation, next slide, please, is going to be delivered by Dr. Sugita Sukumar. Sugi, if you don't mind coming forward and take it away, I'm going to present some more results and findings from the audits and how we can translate this globally. Thank you.
Perfect. Thank you so much, Ajay, for the introduction and also kindly setting the scene. So I'm a clinical oncologist by background as well, and I'm just going to move swiftly now to give you an overview of NATCAN and how we've been able to drive improvement in cancer care through our national cancer audits. Next slide, please. So as Ajay's mentioned, so NATCAN is home to 10 national cancer audits in England and Wales. And we're based here at the Royal College of Surgeons in England, and we work very closely with London School of Hygiene and Tropical Medicine. Next slide. So due to the collaboration that we have between these two institutions, it's allowed us to have a very close clinical and methodological partnership, and this allows us to deliver high quality audit results and quality improvement informed by research and development with very strong methodological expertise, epidemiologists in our team, and therefore we're able to publish high quality publications and contribute to health services research. In addition to this, NATCAN has very close links with a diverse stakeholder group from clinical professional bodies, NHS commissioners and regulators, along with patients, charities, and public. A very key feature of NATCAN and a privilege really here that we have in England and Wales is being able to access routinely collected national data sets. On the right here is a recently published paper on NATCAN giving an overview of the elements that we possess and hopefully some useful key takeaways that you might be able to use in your region or nation. So please scan the QR code here. Next slide. Sorry, thank you. So this is just an illustration here to show, again, the diverse stakeholders that we have and in partnership that we work closely with all the professional organizations, and most importantly, ensuring that the patient voice is heard, because as they say, not about us without us. And Julie will be talking about this in more detail in the last item during the session. Next slide. So as I said, what's very important here is that we have access to these multiple data sets. So it all starts with the data. We have these data sets that allows us to have information about surgery, radiotherapy, systemic anti-cancer therapy, along with inpatient and outpatient information as well. So it's a rich information that we have access to. And since the pandemic, it's more timely than ever as we now have the rapid cancer registration data set to minimize any data lag. To be able to take advantage of this resource, it's very important that we have the methodological expertise to be able to harness this information, which is what NATCAN has and is be able to produce the results we have at the moment. Next slide. So I just wanted to highlight again what Ajay mentioned before about the various activities we have here at NATCAN, and essentially taking this data and ensuring that we, end of the day, produce the impact that we need to see locally. What I'd like to focus on, first of all, is our main output. Next slide. Which is the annual State of the Nation reports. Next slide. So essentially, these reports provide a very concise overview of the care received across England and Wales. It describes the national patterns of care against measurable standards, essentially giving a snapshot to clinicians and other allied health professionals. We also have a patient summary of these reports to ensure it's digestible and understandable by the public. And each audit reports on 10 indicators, and then they provide 5 key recommendations for action. In addition to this, we also have data dashboards, which provides provider-level results, essentially as a form of benchmarking and to identify any unwarranted variation in care and outcomes, and also allows us to carry out our outlier process, which I will discuss briefly later. And as Ajay has mentioned before, and just to quote him as well, the power of NHS data to support major improvements in the quality of cancer care has never been greater. We expect the findings from our audits to be used by NHS trusts to continue to drive the standards and reduce inequalities. If you scan the QR code here, this will then take you to a summary of our recommendations that you can have a look at as well. Next slide. So as Ajay again highlighted previously, there's various performance measures that we can measure across structure, process, and outcomes of care. I'll be giving an example across these different aspects of performance measures. Next slide. So this is an example from the National Non-Hodgkin Lymphoma Audit looking at data completeness. And as you can see across tumor characteristics and also important clinical items such as patients being seen by CNS and also being discussed at MDT, there is a significant variation and very low attrition in terms of data completeness. So the recommendation from the recent report was to ensure there's a designated coordinated clinician within the MDT to take this responsibility to improve data completeness and a particular focus on staging in England and Wales, along with treatment delivery in Wales. And this will therefore allow better risk adjustment and outcomes and allow us to identify outliers appropriately. Next animation, please. And this is an example just showing the variation in terms of data completeness across trusts for staging in Ann Arbor. And as you can see, there's a very wide variation here and far from our target of 90% data completeness, which is why this audit is currently working on a QR intervention to improve data completeness. Next slide. This is an example from the National Kidney Cancer Audit looking at timeliness of treatment. So this is looking at high-risk patients, so patients with tumors which are measuring more than 10 centimeters. And you can imagine how symptomatic these patients are and high risk of bleeding and hydronephrosis. Therefore, it's very important that they receive care quickly. And the national standard at the moment is to ensure that these patients receive a radical nephrectomy within 31 days of treatment. It should be 96%. As you can see here, the average is actually only 68%, with a very wide variation between 29 and 100%. Therefore, this audit has recommended, next, to review pathways for this high-risk group to understand system-level delays and ensure that providers prioritize these patients over low-risk cases. Next slide. This is an example looking at diagnostic pathways from the National Audit of Primary Breast Cancer, looking at triple diagnostic assessment. So this is the national standard for these patients where they should have a consultation as a one-stop clinic where they have a biopsy imaging followed by a biopsy. So this particular code is unfortunately poor uptake within trust. And this is an example of how the audits have used methodological expertise to come up with an algorithm to identify these patients group and be able to report on this indicator. So what they've done is that those who have received a biopsy would have had to have imaging. Therefore, they find the date of biopsy from one data set, and then they look at where the first consultation occurs to see if this coincides. This algorithm would then confirm that patients where the dates are the same are therefore having a triple diagnostic assessment as they should. And what this graph shows is, again, a very wide variation of 6 to 89%, with an average of only 67%. Therefore, the recommendation from the team is to ensure that people with breast cancer have access to triple diagnostic assessment in a single visit. And if this isn't happening, units need to look into methods to increase provision of the service. There has been anecdotal evidence that there's been very high referrals of TDA, and unfortunately, clinic capacity is unable to meet this demand. Currently, there's a lot of work nationally looking at how to streamline the service and creating pathways such as breast pain pathways to divert inappropriate referrals for patients who have to be referred for a TDA. Next slide. Now, looking at an example, looking at variation of treatment. So this is from the National Ovarian Cancer Audit, looking at receipt of any treatment, whether that's surgery or chemotherapy, with patients who are diagnosed within 28 days of an emergency admission. So ovarian cancer patients who present in this manner are very symptomatic, and therefore it's extremely important that they receive treatment quickly to achieve disease control. And as you can see here on the graph, the national average in England is 61.3%, and again, with a very wide variation between 46 and 82% between the gynecological cancer systems. So their key recommendation was for trusts to investigate the results to increase their performance. This audit has currently created bespoke feedback to the different gynecological cancer systems to improve this, supporting them in providing patient IDs so that they can carry out detailed case note review. And it's important that trusts assess eligibility for treatment on the pre-admission fitness of these patients and not in the manner that they're presenting. That is due to the disease and not relevant in terms of any comorbidities of the patient. And it's also very important that there's close collaboration within these systems so that the district general hospitals, for example, ensure open and clear communication with tertiary centers so that they can discuss appropriate treatment for these patients and ensure that they receive chemotherapy and surgery quickly, and they should be prioritized. Next slide. And this is an example from the National Bowel Cancer Audit, which has been reporting on percentage of patients who receive adjuvant chemotherapy for stage 3 bowel cancer. The target's more than 55%, and this has consistently improved over the years at 66% in the most recent report. However, again, there's a wide variation between 47 and 90%. Next. And what the bowel cancer audit has done is, while looking at utilization, also looking at patients who develop any severe acute toxicity. So a lot of methodological work has gone into identifying unplanned hospital admissions from presenting symptoms such as diarrhea or sepsis, which are complications of chemotherapy. And it's found that 1 in 5 patients, unfortunately, still develop severe acute toxicity, again with a wide range, with best performing hospitals at 6% and poorer performing hospitals at 35%. Next. Therefore, the bowel cancer audit has recommended that trust review utilization of chemotherapy if it's below 55% to understand why these patients were not offered treatment. But in addition to this, ensuring they have geriatric expertise to allow for shared decision making with regard to for these patients having chemotherapy, and ensuring that toxicity is also minimized. Next slide. This is an example looking at treatment outcomes. So this is the 90-day and 1-year survival after curative surgery in esophageal gastric cancer. And as you can see, no surgical survivor outliers were identified. And this is reassuring, as it has shown that centralization of services has in fact improved outcomes for patients, as it reflects better multidisciplinary team working and also perioperative care. Next slide. This is an example looking at clinical staffing, again from the NATCAN audit, looking at patients being seen by a CNS, and this data is only available in 2/3 of patients. So although this is being achieved at a reasonably good level at 93%, there was still lower contact seen in patients presented as an emergency or died within 90 days. And as I said, we don't have information for 1/3 of patients and none in Wales, so therefore the audit cannot confidently state that all patients are appropriately being seen by a CNS. And this is an extremely important process for these patients because it's been found that patients who do see a CNS have an overall better experience of care as they are much better informed about their condition, and also referrals are carried out appropriately with the support of a CNS. Next slide. And this is an example just showing the improvement over time from reporting. As you can see, there's been an improvement in 18 of the 22 indicators. And this is an example listing those in green showing improvement in bowel and prostate cancer. And you can see this is over various different types of measures, looking at adjuvant chemotherapy utilization, reduction in 90-day mortality for bowel cancer, in prostate, looking at proportion of those with high risk advanced disease, for example, receiving radical treatment, improving with time. And again, looking at complications of treatment, as you can see with GU and GI complication after treatment, reducing over time. Next slide. And again, this is just reiterating, again, looking at some of our more mature audits, which is the esophageal, gastric, and lung cancer. And again, there's been improvement in multiple performance indicators across different pathways from diagnosis, receipt of treatment, along with treatment outcomes such as post-op mortality and post-op survival. Next slide. So I just wanted to highlight very quickly just a couple other improvement activities, which is our dashboard and also our quality improvement interventions. Next slide. And first of all, the dashboard. So currently we are now doing this on a quarterly basis where we report on data quality in terms of completeness, along with a range of performance indicators at a trust and alliance level. And trust also have the option to download this report. And the idea is to ensure that we are empowering providers to actually be able to access information in a timely manner and be able to take local action. If you scan the QR code here, you'll be able to access our data dashboards as well. Next slide. And I just wanted to touch on a couple of our activities in terms of quality improvement. So first of all, our outlier process. So this is when we flag trusts who have a performance outside the expected range of performance. And we do this by using funnel plots. And once they are identified, they're contacted, the results are shared to them. And obviously this could be due to data completeness or indeed clinical care, either which need improving. The trusts are then encouraged to review this, compare this to an internal audit, and share their improvement plan with us as a form of case studies and shared learning. Established audits in NATCAN have been carrying this process for many years now, and it's been a helpful way in driving quality improvement. Next slide. More recently, what we're trying to do here at NATCAN, obviously we have been doing these fantastic reports over the years, but what we're trying to now harness is actually looking at feedback and making sure that it is done in an active manner. So we of course provide hospitals performance results benchmarked against standard and peers to reduce unwarranted variation, but this only works on the basis that the recipient can interpret the results, they're motivated to change, and have the capacity to act. A recent Cochrane review showed that the audit and feedback, although shows modest improvements, repeated cycle can result in meaningful gains, but it's only effective when done in a proactive, what we call push communication manner. So what the audits are currently trying to do is optimize feedback by altering some of the features of this. And this includes how we're delivering it, who are we contacting, who is the messenger that we can utilize to ensure that this lands with impact to the recipient, ensuring that the content is digestible and the results we produce can be understood by those receiving it, and also carrying out co-interventions such as webinars to ensure that we can support the trust in understanding the results and also acting on this to carry out local change. Next slide. And finally, we want to highlight our Close It Quick collaborative, who's actually having their first meeting today. And what they are trying to do is reduce the rate of 18-month unclosed ileostomy rates after these patients have had anterior resection. And unfortunately, since the pandemic, this had increased from 33 to 38% over the years. Next slide. So this collaborative is being carried out in conjunction with the Royal College of Surgeons in England. And what it does is that it's a subscription model where trusts can pay into its collaborative, and essentially they obtain support from clinical and QI experts. There's webinars and collaborative events allowing peer collaboration, access to bespoke data dashboards, and resources such as shared decision-making tools, discharge diary, and a checklist prior to ileostomy closure, which is developed over a series of workshops with. And following in the aim of this collaborative essentially is to spread learning and be able to carry out improvements at scale. Next slide. So how can we translate what we do here at NATCAN globally? So first of all, it's important to define who you're measuring and establishing patient cohorts from data that's routinely available, prioritizing questions that matter most locally. So focusing on high impact challenges that is most relevant to your region or nation, using performance indicators that drive improvement, making sure they're relevant, measurable, and actionable, benchmarking to reveal any unwarranted variation by comparing to clinical standards or national or regional averages of peers to highlight variation and inequity in care. Next slide. So, as I said, start with data you already have. The initial audits do not have to be perfect, but ensuring you have consistent minimum data sets and joint leadership is extremely important. So, identifying a model that works locally, which allowing collaboration between universities and cancer centers. Next. Along with this, perhaps starting at a regional level rather than a national publication to start, using local champions because data only drives improvement when clinicians trust it. So it's very important that it's clinically led. Next slide. Along with this, tracking high impact indicators, as I said, and things that are most clinically relevant, whether that's time to diagnosis, proportion of patients receiving a treatment, 30-day mortality, or availability of molecular testing. And focusing on system-wide equity. And by doing this, it will be helpful to identify any inequalities of care, which can be done by looking at determinants of treatment variation, looking at whether this varies at a urban versus rural location, age, gender, and also ethnic minorities. Next slide. So that brings me to my final slide. So thank you very much for your time, and please post any questions you have in the Q&A. I'll hand back over to Ajay.
Thanks very much, Sugi. As Sugi mentioned, please put your questions in the chat. We've got a couple of questions already, which we'll answer towards the end of the session. If not, we'll write comments in there. So delighted, next slide, please. Delighted to invite Dr. Kate Walker, Professor Kate Walker, who is lead of a number of the different audits and our senior statistician across NATCAN, who's going to talk about harnessing audit data to uncover disparities and influencing clinical practice change. Kate, please take it away.
Thanks very much, Ajay. Thank you to you and Sugi for setting the scene so nicely. So we've talked a little bit so far about the methodological clinical partnerships in these audits, and I'm going to talk now about how we develop our methodology and how research and audit go hand in hand in NATCAN. Next slide. So I like to describe this in terms of this following diagram of how we can uncover disparities to eventually drive practice to drive change in practice. And this all starts with having rich, timely, big data that's already been described. And then from that, we need to be able to measure the care according to each provider. For that, we need to often develop new performance indicators. In order to make fair comparison between NHS providers, we need to accurately risk adjust for the different case mix of patients at each provider. And we need to have reliable methods of reporting, so timely, reliable feedback, making sure that we have sufficient statistical power. For example, to be able to identify outliers, as described earlier. And then once we have all these methods in place, then we need further work to understand the variation in care so that we're establishing what are the drivers of that variation to ultimately drive change in practice. I'm going to start first with the rich, timely data. Next slide. And you can see we are very lucky in NATCAN to have, I think cancer really in this country is the clinical area with the richest available routine data, richer than ever, more timely than ever. And we have a development that occurred during the COVID pandemic of having what's called the rapid cancer registration data with a much shorter lag. And we have drops of that into NATCAN every quarter. And I won't go through all these data sets, but you can see there are bespoke hospital administration data sets, SACT, radiotherapy, etc., etc. But in order to actually make good use of this rich data, it does require methodological development to be able to exploit it. Next slide. So back to this picture, I'm going to start now with indicator development. I'm just going to give you a few examples of the sorts of indicator that we've been able to develop over the years in the cancer audits. Next slide. So this has already been talked about, I think, about how we select and prioritise our indicators, but it is really a crucial step before we come on to the development, is that we're ensuring that we can measure the indicators, we feed them back, and they're actionable and improvable. Next. So on to the next slide. I'm going to give you some examples of the sort of data science work that we do in our cancer audits to accurately phenotype care. So we usually carry out what's called a clinician-driven forward search, where we're using publications, guidelines, clinical expertise to come up with sets of codes which would indicate whatever our outcome is. And then we support that, we enhance that with a data-driven backward step, where we're looking for additional codes which pick up idiosyncrasies in the coding. You know, this is crucial when we're using this sort of routine existing data. So I've got some examples here. There's a further example as well, Aurelia, of some indicators we have developed on, first of all, urinary complications after radical prostatectomy, all picked up just using hospital administrative data. So this is using ICD-10 diagnostic codes. Very happy to be able to share that we have just had published only last week our new indicator to pick up occurrence of curative colorectal cancer resection using, you know, this very rich data. But actually 94% of the recurrences we've been able to pick up have come from just the hospital administrative data using international standard ICD-10 diagnosis codes, OPS4 procedure codes, so, you know, transferable globally wherever there is available hospital administrative data. And there was one more example. Next, please. And that was on, similarly, this is identifying the severe acute toxicity after adjuvant chemotherapy for colon cancer, which was developed to be a broad indicator that could pick up toxicity, not just in colon cancer chemotherapy, but elsewhere, and we are expanding that work to other cancers in NATCAN. Next slide, please. So back to our picture, just say very briefly, we do quite a bit of work on accurate risk adjustment, and we've developed risk models. Next slide. Probably the most famous of our risk models is the NELA, National Emergency Laparotomy Audit. We were behind that risk tool, which gets used for emergency laparotomies. We also published on our risk adjustment model for bowel cancer resection, and, you know, using modelling nonlinear relationships, interactions between risk factors, so some accurate predictive modelling methods used there. Next slide, please. I'm going to skip the methods for reporting in the interest of time and move on to understanding variation. I've got some really interesting examples to share here of published work where we've been able to pinpoint what is driving the variation in care. So next slide. Examples here include the top left is an example from breast cancer audit where it's been looking at age at diagnosis and how that influences the receipt of post-mastectomy radiotherapy. Moving to the top right, looking at variation in radical local treatment for men with high risk, localized or locally advanced prostate cancer, picking out the determinants of that variation. Bottom left, this was some work where the prostate cancer audit collected patient-reported measures and found relationships between hospital volume and those outcomes. And then bottom right was looking at the impact of centralising the services for treatment of prostate cancer and the effects of that. So I'll go into a little bit more detail on the next slides. Have the next slide, please. So first example is from the National Prostate Cancer Audit. And this was looking at potential undertreatment of locally advanced disease. And what's really interesting is that when the prostate team looked separately amongst 80 and over patients on the left versus those aged 70 to 74 on the right, you can see in these funnel plots that there was wider variation in the older patients. So it's helping to pick out where that greater variation is. Next slide, please. And what was really interesting was to look at the relationship between age and the proportion getting curative treatment. And what was found was that age was by far had a far stronger relationship with the chance of getting that curative treatment than comorbidities. So really highlighting some potential issues with undertreatment there. Next slide. This is a different example from the bowel cancer audit where we looked at the variation in access to liver resection for patients with metastatic disease at diagnosis. And first of all, finding socioeconomic disparities. We've lost the slides there, Aurelia. We can see you. Thank you. And we found that there was a real gradient there with deprivation quintile according to small geographies of residence of the patients. So comparing the least deprived quintile of patients to the most deprived, they were 1.4 times as likely to get a liver resection. And next, please, you can see that in a very similar piece of work, we also looked at the centralisation of that treatment, so liver resection for metastatic disease. And we showed that it really mattered where you were diagnosed because patients diagnosed where there was a specialist hepatobiliary service were 1.5 times more likely to get a liver resection in what we call a hub centre compared to patients diagnosed in a spoke centre. So highlighting issues there with the referral pathways through. Next, please. And that actually, that was borne out as well in the survival. So we were finding poorer survival in the spoke centres. So moving on now onto what's going on with NATCAN and global cancer care. So starting with an example from the bowel cancer audit, we were part of setting up this international colorectal cancer outcomes registry collaboration. I'm the chair of that group and we're growing, but you can see we already have quite a spread of representation. Actually, there's quite a few countries there in Europe. You can't distinguish between them on the map. But next slide, you'll see that we are aiming with that collaboration to compare care and outcomes of patients with colorectal cancer internationally, aiming to use our collaboration for sample size boosting. That's not quite happened yet. Promoting shared learning on how we can drive improvement in care, but also really important, I think, encouraging anyone who is interested in setting up a new cancer registry or audit to be part of that collaboration so that they can get learning from the established audits. Next slide. Some examples of the work that's come out of that collaboration. So this was a sort of proof of concept for the collaboration where we didn't send patient level data overseas. Each country analysed their own data. We shared analysis script and then we put together the results. Next, please. You can see how we were able to compare how the surgical approach to rectal cancer has evolved over time, and the different colours there, the yellow at the top is open surgery, whereas the dark orange is minimally invasive surgery, and it was rolled out over time along the horizontal axis. You can see it's rolled out quite differently in the different nations. So that was really, it was interesting, but it was also a proof of concept to see how we can carry out analysis across the countries and pull those results. Next slide. Another paper published out of the collaboration is work to compare the data items collected to identify a common data dictionary across the registries. Next slide. And we've got current work on a Delphi exercise to agree a minimum data set, and also to look at case mix and outcomes of patients undergoing major resection by age, with a particular focus on the over 80s. And then we also have, in the planning stage, work to compare waiting times for treatment between different countries. Next slide. So thinking about getting started with an audit or registry, first of all, I can share some of my reflections on the early days of the National Bowel Cancer Audit. I got involved in 2010, so I can't comment exactly on the very early days. It started in 1999 as a clinician-led voluntary audit, just patients undergoing major resection for bowel cancer. And I think crucial to its success was that it was started out in partnership with a professional body, the Association of Coloproctologists of Great Britain and Ireland, and that partnership has continued to date. Also, really important, as has been said previously, to have wide stakeholder involvement. So that's across all the different specialties of clinician, nurses, patient representatives, charities, etc. And over the time, I think, the biggest issue with setting these registries up is on actually getting the data in. And what we've found is that data capture and data completeness has improved by reducing the number of data items to just really the most important core items. The fact of just reporting by provider and by outlier reporting, I think in itself is a real driver for improvement of the data. And then in this country, I guess we've been lucky in that there's a lot of existing data sources, but across the world there are often reimbursement data sets, hospital administrative data sets, and that's probably been the most crucial data source to link to. Next, please. 26 years later, we are now a mandatory audit covering all colorectal cancer patients. We've broadened not just to the surgical, but to all modalities with a wider set of surgical and oncological indicators. And I think I have one more slide, please. And I also just wanted to reflect on an example from our international collaboration, which is with work from Nicolas Avellaneda. He set up a new registry of colorectal cancer in Argentina through absolutely tireless work. And he did that through collaboration with established audits in the international collaboration. And he's also tirelessly working to bring his learning across other countries in Latin America. Starting out with a clinician-run voluntary audit, just in a very similar way to here with the National Bowel Cancer Audit. And I think from the learning from others, reducing the number of data items to just the core items, starting small with a pilot study of 8 centres, just running for 6 months in 2022, and then with a plan, a 5-year plan, to add 9 hospitals every year. And really impressive that he's achieved over 95% data completeness on all the data items. And the latest update from this year, next, is that they've managed to include, next point please, over 3,000 patients now. They're seeking funding, and they're already finding evidence of poor outcomes associated with low volume centres and non-specialist surgeons. That was all for me. My last slide is just to say thank you for listening, and there's my email.
Thanks so much, Kate. Some fabulous lessons there. And I think what I particularly liked with the last slides is that it's a process, and it starts small and builds up, but that whenever you measure, you start to investigate and find things that can improve the quality of care at scale. But then also, as you go more broader with data sets, the statistical aspects and the methodological aspects are increasingly important for fair comparisons. So I'm going to lead us on to our next slide. Please keep putting questions through the Q&A. We've got Dr. Julie Nossiter, who's our Director of Operations at NATCAN, is going to explore and discuss some of our fantastic work integrating the patient voice and delivery of our quality management program. Take it away, Julie.
Thank you very much, Ajay. Okay, great. So thank you, Aurelia. So next slide, please. So in preparing this presentation, I came across this quote from the King's Fund, which is a public health think tank in the UK. I really like this quote. So people and communities using health and care services are best placed to understand what they need, what is working, and what could be improved. So participation gives patients and their families a voice in improving cancer services, but it also helps to improve care and also provides emotional empowerment for patients and their families. So there has been a shift to patient-centred care in the UK and more participation in developing health policy. So this very much underlines the principle that lived experience is as valuable, this is very key, as clinical expertise in shaping health and care services. So what have we been doing in NATCAN to ensure that we ensure that patients and carers, that their voice is central to all of the work that we do? Next slide, please. So within NATCAN and the cancer audits, we're incredibly fortunate. We work with a broad range of stakeholders, so a broad range of professional stakeholders, the different professional societies, but also key are patient charities. And we're very fortunate to have a very broad range of patient charities specific for particular cancer sites. So Kidney Cancer UK, for example, Prostate Cancer UK, but then also Pan Cancer, so Macmillan Cancer Support, Cancer Research UK. So within NATCAN and across NATCAN, we work very closely with our patient charity partners and collaborators, and we utilise their networks and their expertise to ensure that we have representation within our governance structure and within our planning and decision making. Next slide, please. So these relationships that we have with our patient charities, we very much utilise those to develop a standalone patient and public involvement forum for each audit. I think it's fair to say that within NATCAN, we have very limited, we're comprised of very small teams of people. Each audit is a very small team, and we have very limited budget. We don't have a huge budget to utilize and maybe do all of the activities and work that we'd like to do engaging with patients. But because of the relationships we have with the patient charities, we're incredibly fortunate to be able to work with them, to tap into their existing patient networks. So, for example, their various support groups, and we utilize those, and then also the administrative support from the patient charities themselves to recruit from their networks, from their communities, to recruit to our standalone patient and public forums for each audit. So there were a number of different approaches here. There were some excellent examples of using social media and pop-up adverts on the patient charity websites to reach a wider audience. So people visiting the website who may not have been a part of one of their patient support groups, we reached out to people in that way. Within the audits and across NATCAN, as Sugi mentioned, there's a number of long-standing audits like bowel, lung, prostate and OG. So these long-standing audits could then share resources and learning from their patient panels. So could share recruitment expertise, and also materials such as terms of reference, developing adverts, expression of interest forms, and patient booklets. So this very much fits into, this is only possible because of wide collaboration using limited resources. Next slide, please. So key to make the effective representation, you need to ensure that you have appropriate representation in each of our PPI forums. So working again with the patient charities and their expertise, and also our clinical leads in our project teams, we ensured that we had geographical and aimed to ensure that we had geographical representation and representation across age, ethnicity, types of treatment, stage and risk group at diagnosis, and gender as appropriate. So there's an example here from the lung cancer audit, and the lung cancer audit recruited via two key patient charities, the Royal Castle Lung Foundation and the Ruth Strauss Foundation. Each patient PPI forum has a chair, and they meet every 6 months, but then there's lively sort of interaction in between those times. Next slide. Thank you. So the next couple of slides just give some examples of some of the activities and outputs. So a key starting point was for each of the audits, each audit developed a quality improvement plan, and the working with our PPI forums has shaped what our quality improvement priorities are. As Sugi mentioned, these are being taken forward into QI interventions, and so there's an example here on the right-hand side from the ovarian cancer audit, where they're focusing on improving treatment rates for emergency admission. And there's been sort of discussion and involvement with the PPI forum, who are very much supportive in selecting this first indicator to go forward for this first QI intervention. There's been a number of different QI activities, so these range from webinars, as well as providing information, materials and resources. Again, thinking about limited resources, a lot of our sort of interaction, I would say, and this works when people are living in different parts of the country. A lot of it is virtual, like the meeting today. Within NATCAN, we do aim to have a face-to-face meeting every year, but for example, we don't have, unfortunately, we don't have budget to be able to pay for people's, we pay for travel, but we don't have budget for accommodation, for example. So we use our limited resources, and any additional support that we can get from our patient charities is always welcome and helps us in this regard. Next slide, please. Other activities and outputs. So as Sugi mentioned, each audit publishes annual State of the Nation reports, and the audits work with their PPI forums to develop summaries of these, and they have a key involvement in development of infographics. Again, working with our patient charities, the audits get involved in the monthly cancer awareness months. We have a really good example here from our PPI chair of the non-Hodgkin lymphoma audit, who prepared a blog for Blood Cancer Awareness Month. And then there's an example here on the left-hand side from one of our newsletters. So this is very much on the ground, linking up with those sort of regional, local patient support groups. There's also, we've also worked with our PPI forum members. We've developed a new website this year. We've developed a data dashboard, as Suggy mentioned, and they've very much been key in the consultation exercises during the development of both. And we're also always very welcome for suggestions and ideas and contributions to our communications via our website and social media activities. Next slide, please. So the National Prostate Cancer Audit was unique within the cancer audits within NATCAN. Before the prostate cancer audit, when it first started in 2013, prostate cancer audit was unique in having an additional funding stream to enable us to develop a patient survey. Next slide, please. We've discussed a lot today about the different data sources that we use. The prostate cancer audit was the first to use routine data only, was the first cancer audit not to have a bespoke data collection platform. And like I mentioned, the prostate cancer audit was also unique in that we had additional funding to enable us to develop a PROMS and PREMS program. Next slide, please. The reason we managed to get additional funding for the prostate cancer audit to develop a patient survey is that patients, fortunately, patients undergoing radical treatment, so this is surgery or radiotherapy for localized non-metastatic prostate cancer, may survive for many years following treatment. And there are a lot of patients who are living with potential adverse impact on their sexual, urinary and bowel functioning as a consequence of their radical treatments. So for prostate cancer, we developed a patient survey because we wanted to find out from patients themselves, firstly, what the impact of the treatment, that these radical treatments were having on their functional outcomes. And secondly, to find out about their experience of care. So both the PROMS and the PREMS measures provide a measure of the quality of care, which is one of the key dimensions alongside patient safety and clinical effectiveness. Next slide, please. So the patient survey aimed to determine variation from one hospital to another. So as I mentioned, we wanted to measure functional outcomes after radical surgery or radiotherapy, and also patients' experience of care. So again, collaboration was at the key of this and consultation. So we developed our questionnaire, consulting both with clinical and patient reps. So the survey included both generic and disease-specific validated instruments, the EPIC 26, which is specifically for prostate cancer. And we also selected relevant questions from the National Cancer Patient Experience Survey, which runs in the UK. The survey was sent to men at least 18 months after diagnosis. So we chose this time point to take into account that, so that we were asking questions about functioning that were, once patients had got to a steady state after their treatments. We didn't want to send out a survey because obviously in the immediate aftermath after receiving treatments, it'll take a bit of time. We wanted the patients to have recovered from that in the first instance. So we had a successful patient engagement, very high response rates, which we were delighted with. So the survey was sent to over 60,000 men and 73% responded. So this was just under 45,000 men, which was fantastic and is an incredible resource. Next slide, please. So what are the outcomes reported for men after radical treatment? So the survey using the EPIC asked questions related to urinary, bowel and sexual function. And then the answers to these questions were then used to generate a validated summary score ranging from 0 to 100, with the higher scores representing better function. And then we linked these results from the patient survey to the routine data. So this enabled us to then have information about patient characteristics, tumour characteristics, disease status. So this enabled us to risk adjust also for to account for case mix. So when we're comparing providers, we can carry out fair comparisons from one hospital to another. Next slide, please. So this is just an example for patients undergoing radical prostatectomy. We saw variation from one surgical centre to another. It was clear that patient's sexual function was very significantly impacted, but there was variation. This did vary. We used this to develop performance indicators using the EPIC urinary incontinence scores and also the sexual function scores, and then also the bowel function scores, which was particularly of relevance to patients undergoing radiotherapy. So we used these also to develop performance indicators, which we put through the outlier process. Next step. Sorry, next slide. So the overall key findings, we found that, as I mentioned, there was significant variation in care. This was both, which I haven't showed the results for yet, for experience of care, but as well as hospital outcomes. Patients, as I mentioned, reported poor sexual function after radical treatment, both surgery and radiotherapy. And patients also reported problems with urinary incontinence after surgery and bowel issues after radiotherapy. Next slide, please. We also utilise the PROMS measures to do comparisons from different treatment modalities. So the audit has, has been taken, the prostate cancer audit, there's been an explosion in treatment advances since the audit started in 2013. Ajay's already mentioned about the rapid adoption of radical prostatectomy. Robot-assisted radical prostatectomy. So we used the PROMS results to explore looking at different surgical modalities. So we compared robotic with open with laparoscopic, and we found no significant differences in functional outcomes for patients from one surgical modality to another. We also compared, there's been big advances also as well in radiotherapy treatments, and we compared hyperfractionation versus conventionally fractionated radiotherapy. And again, we saw that there weren't any differences in functional outcomes being reported by patients, which supported there's been a number of key RCTs, which have also looked at comparisons between hyperfractionated and conventionally fractionated radiotherapy, and our work further supported the move to use of hyperfractionated RT. Next slide, please. Using the PROMS measures as well, we also identified unmet needs. So there's an example here. So our work demonstrated that there's a large number of men living with severe bothersome urinary incontinence following radical prostatectomy, but very few of these men undergo incontinence surgery, which could potentially help to reduce these issues. We looked at determinants of variation, and we found out that of the men who actually do undergo, they are typically who do undergo incontinence surgery, they're typically younger, white, and have fewer comorbidities and live in less socioeconomically deprived areas. Next slide, please. So the key learnings for the PROMS, we demonstrated that PROMS are important for audits of services that aim to improve or protect functional outcomes. They provide a measure of safety. They also provide additional information over and above what clinical data or routinely collected data provide. Changes in clinical measures may not always translate into benefits for patients. They're important tools for measuring the impact of ongoing changes in practice. And thinking about the outlier process, the clinicians never disputed those indicators that were on the basis of the PROMS validated instruments. They accepted these as authoritative information. And from our interaction and consultation with our PPI forum, it's clear patients want PROMS. These provide patient-centered care and shared decision-making. Next slide, please. This slide just also demonstrates, goes into a little bit about the key learnings from the patient experience measures. It's clear that there's variation, and then we looked into the determination of variation for this. So the patients who, there was variation in patients reporting that they had access to information about their treatment and their condition, and also variation in their involvement in their care. And we saw differences, older patients, Black and Asian patients also reported more negative outcomes. So more negatively being less involved in the decision making. We also, this paper also demonstrated, and this is really key, that working with our PPI forum members, we invited our PPI forum members to become co-authors on the paper, which added a much richer and important dimension to this work. Next slide, please. So moving forward in NATCAN, we're setting up a NATCAN-wide PPI network. I won't go into this in great detail, but there's a fantastic quote here from Olivia, one of our clinical fellows. So I really love this quote. In NATCAN, we don't use names or NHS numbers, but every number in our data represents a person, a life, a story, a family, and we have a responsibility to use that information with purpose to make better care, fairer care, and faster care for everyone. Final slide, please. So thinking about learnings from our, embedding patient voice in QI programs, it's key to partner with existing community and, if possible, national structures, use low-cost communication channels and activities, ensure appropriate representation across patient groups, and focus on outputs that add value. These can be simple, low cost, but very meaningful. Use existing feedback loops to influence patient practice. Proms and prams are quality tools, but unfortunately, additional funding is required for these. That's my final slide. And I think Aurelia, my final slide is just to say a big thank you. And I'd really like to thank, in particular, members of our PPI forums and our patient charities who support our work. Thank you very much for listening.
Thanks very much, Julie. I'm now going to invite our panelists or discussants onto the screen. Aurelia, if we could remove the slides, please, and if Sugita and Kate could join. Fabulous. Great. We're a big team. I would like to say we're all in the same room. Okay, just to kick us off, I mean, probably people listening are going to see the sort of wide variety of activities, but these were built over many years. We're now in a position where we're using more rapid data, and that in order to try and feed back in a more timely way that can influence outcomes of care. Now, we've had a few questions around the actual data itself, and we've provided some responses, but if I could come to you, just Kate, more broadly, there is a sort of general query about, this data is reported. We've talked about the robustness of the data from our end. This is what we receive externally and then report back. But what is your advice with regards to individuals or hospitals not necessarily recognizing the data?
Yeah, thanks, Ajay. Really important. And, we've moved over to using existing data sources now in NATCAN. And that helps to reduce burden within the NHS providers. But, we know that leads to questions about the robustness of the data. So do go to our FAQs on the NATCAN website, because there's links there to resources of places you can use to check in even more timely way your data completeness. So there's the Cancer Stats 2, which is almost real time, which allows you to look at data completeness. But also you'll see Andy Murphy's put questions up on the chat as well. And, I'm sure he would say the same as me. Please make use of the National Disease Registration Services staff who are available to help support. So the data liaison managers, they work regionally, and we have links to them with their contact details on our FAQs. So get in touch with them as soon as you see any issues or you've got any questions about the data that you're seeing that doesn't look right.
And I think, just to add, Kate, I think with new audits that start, there is always often a discrepancy of the data as the audit matures itself. I can only say firsthand, particularly from the prostate cancer audit, is to sort of ignore the result at one's peril. You'll either find that actually the people who are inputting the data haven't been as required, or are unsure, or have not had the clinical leadership that's required. So as much as we expect it to be devolved to other people in the hospital, I think every clinician who wants to see what the quality of the care is has to expect that they might have some responsibility about how that care is inputted. So that's the first thing. Second of all, even when you get a result, and again, from first-hand experience, your natural inclination is this is incorrect. And it may be a data issue, but equally, a lot of the care that we're providing, we're not doing anything wrong in terms of following evidence-based pathways, but there are iterations in care that are happening all the time, and that's an element of quality improvement. And what we've not been able to do is learn from hospitals who might be doing it better or concentrating on performance. Again, I'll reflect on the radiotherapy example. We had I think an 18% GI toxicity rate. The average was 10%. That's at my own hospital. We asked, we were unsure. We did a huge audit of ourselves internally. So I think that's the way to think about it. The result comes, there's a signal there. Something is not right. We still have to look at our local data. We looked at our local data and we found that the percentage was there or thereabouts. There might be 1 or 2% here and there because there was no obvious data missing. We then needed to work out what to do, and that's not easy, but we spoke to the centres that were offering the best care, and we found that they were running their service like an F1 company. And those iterations, those protocols we've adopted, and since then, over a 2-year period, our toxicity rate has gone from 17% to 7%, and that's just been now published. So it's just a message to the clinical community that whether it's due to data or whether it's due to improving performance, across the board, there's always scope for improvement from the data that we report. So please do look at that. And I think that goes in hand, Andy, in terms of what we're trying to do or what we're seeking to do is to use indicators that matter for clinicians. And that's why we're moving much more from process to outcome measures, because actually fundamentally that drives practice. I think there are some changes where it was the self-reported audits. So I think esophageal cancer and bowel cancer in particular were good examples. However, we also have seen when we compare self-reported data from external data, which has been using the same approach, that there can be a difference in the actual inputting when people are self-reporting it. And I'm sure people are as assiduous in reporting it themselves, but often it's not the case. I wanted to just go on to Julie, if that was okay, whilst we wait for more questions, which was really around how do you start the dialogue with patients? Because people might ask, are these patients the patients that you see day to day in your clinical work, or are these patients who are have to come from particular representative groups? What is the level of advocacy and literacy around health to be play a meaningful part in audit or other initiatives?
Yeah, I think that's a good question. I think, and we're really fortunate that we work really closely with the patient charities when we're recruiting for patients. So we want to make sure that there's, we advertise like we would do for a job, if that makes sense. It's kind of there's certain criteria to be met. For example, I mentioned a lot of our meetings are using Teams, for example. So it's, there's some sort of basic criteria and basic sort of knowledge that will be required to be able to participate in the way that we participate. But I think maybe it is a point that you're making as well, Ajay, is that by doing that, are we missing out on certain groups of people?
Potentially,
yes.
But I mean, it's not an easy
point.
thing, isn't it? But I think it starts from the experience and the qualitative work, and then leads to more the sort of practical co-design elements. I think it's a transition. So for other countries thinking of adopting this, bringing in patient experience full stop is a slow process and breaking down those hierarchies, but again from a mature system. Final question to Sugi, because I know we've only got a couple of minutes, was you've reflected on how we're really trying hard to use this data to influence downstream impact. Can you just talk maybe a bit about the role of targets maybe, and how we can just, the data that we have, how we can feed it back in a way that's more meaningful? If you could just briefly comment on that.
Yeah, so I think target setting is a very useful way, especially benchmarking ourselves to the national average. But I think what's also important is that instead of looking at it as sort of a red line, whether you're achieving a target, good or bad, it's actually looking at improvements over time that may vary. Because for a trust that is consistently, let's say, achieving 90%, even though the target's 85%, there's no reason they should thrive to be even better or continue to achieve higher standards. And for another trust that is further down the line, even they may not achieve the target of 85%, for example, but consistently are moving towards this green line. I think that's the attitude people should take, what we call a green line approach, rather than looking at something as a binary outcome essentially. And I think that's really important, that when targets are being set, that is how it should be looked at, and it shouldn't be where people are trying to use sort of a gaming way of trying to hit targets, because sometimes that can have a negative impact as well. So I think it's very important in any policy that's being written, in terms of how they sort of frame the target, and also accounting for looking at how it can drive improvement, and looking at different facets to ensure that we are using targets in an appropriate way to drive improvement.
Sugi, and it's an area ripe for research. We think that we can work out targets across a range of indicators, but actually there's no clear consensus in the literature at present. So we're learning as well, and we're hoping to try and furnish the sort of wider community with the literature to support other endeavours, whether locally or internationally, as we go through this. I think we've now reached time, I'm afraid. Thank you for extremely rich discussion. I thank you, the participants today, so Julie, Sugi and Kate. Pleased to say that everything will be online. Thank you so much for the attendees. We've had well over 100 and extremely good questions. There will be others. Just please check our NATCAN website. If you put NATCAN Cancer into Google, you'll find us. And we're very happy to take any questions, explore collaborations, and discuss interesting research questions. So thank you again for your time. Enjoy the rest of London Global Cancer Week. There's some really interesting sessions, and take care. Thank you.
Bye.